I welcome you all for the last session of Stroke SIG, the last session of AOS in India for this year 2023. And today we have a guest lecture on recent advances in the management of pediatric stroke. I request our President Dr. Shipali ma'am to introduce the speaker and the experts for today's session. Over to you, ma'am.
Thank you. Thank you so much. Thank you, Dr. Lisa, for having accepted this invitation at this part of the year, which is a festive season. And today, would like to introduce her. She's Dr. Elizabeth Pulsine, an assistant professor of University of Toronto, staff physician, Division of Neurology, Hospital for Sick Children, Toronto. And she has a research interest in childhood stroke, including all aspects of stroke. And she's a member of the International Pediatric Stroke Organization, American Congress of Rehabilitation, ANN, American Heart Association, and many, many, many more. And we are very happy to have you here. And as what we have been doing is we have one speaker from one particular resource country, and if you have a high income country, then you have the experts from the low and middle income countries to discuss. So we have Professor MV Padma, who was former chief of CN Center, AIMS, New Delhi, and she is currently chairperson of neurology in Paras Hospital, Gurgaon. She is a very dynamic and a very experienced person, and stroke has been very close to her heart amongst many other things, including multiple sclerosis. And she has been conferred Padam Shri by Government of India and innumerable awards and publications. Thank you, ma'am, for being here. Then we have Dr. Tipu Sultan is about to join. He's head of neurology, pediatric neurology from Children's Hospital, Lahore, and stroke is among his areas of interest. And he'll be hosting the next the Association of Child Neurology Association, Asian Oceanian Child Neurology Association's next Congress. And we also have Dr. Kalpana Vijay, who's senior consultant pediatric neurologist, Kimshit Health Hospitals, Thiruvananthapuram, Kerala, who has a vast experience in child neurology. And the session will be moderated by Dr. Manish Parekh, who is a dear friend and senior professor and head of pediatric medicine in Dr. SN Medical College, Jodhpur. And he himself has had training in Canada, and knows Dr. Liz for long. And thank you, all of you, for being there. And I'll hand it over to you, Dr. Manish. But before I do that, can I just have the conference flyer 1 second? I would request all of you, Sangeeta, can you just speak in 1 minute about the conference? Sangeeta.
Yes, ma'am. Good evening, everyone. On behalf of organizing committee and AOCN team, I would like to extend a warm welcome to Vellore to attend the 14th annual conference of Association of Child Neurology India. The conference will be held from 8th to February, 10th February 2024 at Bagaim campus, which is called as the Lush Green Valley of Christian Medical College, Vellore, which is surrounded by the ancient hills of the Eastern Ghats. The conference includes one-day pre-conference workshop encompassing 5 important subspecialties in child neurology, which includes neuroradiology, electrophysiology, pediatric sleep disorders, neurodevelopment and behavioral pediatrics, and pediatric epilepsy syndromes. The main conference includes 2 days of cutting-edge deliberations by the national and international experts. And we have a preliminary and final round of quiz with exciting prizes to motivate our pediatric neurology fellows and residents. We also have an exciting cultural event on 9th February evening depicting classical and semi-classical dance program. So the early bird registration has been extended till 31st January 2024, and abstract submissions have also been extended till 31st December 2023. So please hurry up and register to enjoy the academic feast at Vellore. Thank you. Thank you, ma'am.
Thank you, Sangeeta. I hope you're keeping some cultural events too. Just for those who are joining first time, what we'll have is the talk for 45 minutes to 1 hour. That's the liberty of the speaker. And then we have the speaker today is from a high resource country. So we have experts who will be discussing. We are having 2 pediatric neurologists, one from Pakistan and one from Trivandrum, and we have one adult neurologist, Dr. Padma. So we will have varied amount of discussion. So the last half an hour to 45 minutes is on the discussion. And I think that is what, interaction is there, and that is how we are looking at all these sessions. And over to you, Dr. Parekh.
Thank you so much, ma'am. And I welcome Dr. Pulseen. Dr. Elizabeth Pulseen she's a fantastic neurologist, a great teacher, and every time I meet her, she is one of the most humble persons I've ever met. The full stroke team at Sick Children is dedicated and devoted to a lot of research in pediatric stroke, and Dr. Pulseen has a great interest in stroke related to congenital heart diseases, and she's published very well, and we have been following a lot of her publications as well. So did I just snap my internet connection, or was I audible?
You were audible.
Am I audible?
You're all good.
Oh, okay, great.
You're audible.
So,
yeah.
and I express my gratitude to her for accepting this invitation just, during the vacations. And Merry Christmas to you, Dr. Pulseen. And also, thank you so much. We know it's difficult to adjust in this vacation time. I also thank all the experts here. And as Madam Gulati, she has been the driving force behind all these activities. And as we have many times we have stressed the fact that almost this event is being, the participants are from around the globe, almost 240 countries. Madam Gulati will tell you how widely this is being participated. So it's one of the pleasures to have our experts here. And also, I would let all the attendees know that they're free to ask questions after the session from Dr. Pulseen is completed. And so, Madam, over to you again, Madam Gulati, for inviting the speakers and the experts to here.
Thank you. Dr. Elizabeth, I forgot to ask your permission for recording. We have been recording all the sessions and putting them in our YouTube channel, which we have. And our attendees have been over 40 countries. And so they are coming on the YouTube channel of AOCN. So if your permission is there, can we record it?
That's of course, not a problem.
Thank you so much.
Okay.
Thanks. Please, you can start sharing
Okay.
the screen. Thank you so much. The Christmas tree is very nice behind you.
Thank you so much. I hope
you
you can all hear and see me. And sorry, I'm having some feedback from my headphones. So please feel free to interrupt at any point. If all of a sudden I lose connection, I'll just take them out. Let me just blow up my screen and I will begin. I just lost, oops. Forgive me, Zoom, we use Microsoft Teams. So Zoom is like my second.
Yeah, you can share the whole screen. Yeah. You can share your whole screen.
There.
Yeah, perfect.
Okay,
yeah.
everybody can see that. So first and foremost, I just want to thank the Association of Child Neurology in India, the Stroke Special Interest Group in Stroke, Professor Gulati, Professor Prakash Parak, for inviting me to give this talk. And I'm very happy to do so. This kind of sparks my joy. I love pediatric stroke, which is probably why I went into it. I'm a neurovascular neurologist at the Hospital for Sick Children and also the fellowship director in the Children's Stroke Program. So if you ever have any interested trainees who want to come over and do a fellowship in pediatric stroke at Sick Kids, please, at the end of the slides of the presentation, you'll see my email. So please feel free to contact me. So I know I have a lot to get through, and I really am going to try and focus on the more recent updates in the management of pediatric stroke. And we'll hopefully leave all the questions. I'm not monitoring the question and answers, but at the end, I'm happy to answer as many questions as time allows. So I have no disclosures that are relevant to this talk. And hello from Toronto, where it's actually raining, not snowing. And again, just learning objectives. We're going to recognize why it's important to have timely diagnosis of pediatric arterial ischemic stroke. And for the purpose of this talk, I'm really going to focus on arterial ischemic stroke, but there are many different types, including hemorrhagic and venous. I'm going to talk about evaluating strategies to optimize outcome following stroke, and also, of course, evaluate the current knowledge base regarding the use of hyperacute therapies in children with arterial ischemic stroke, and in some certain special populations that are near and dear to my heart, like the cardioembolic population. So when I think of pediatric stroke, I think of Where's Waldo? And why? Because unlike neonatal arterial ischemic stroke, no two stroke cases are alike. And there's often many mimics and subtle presentations that make this a diagnostic odyssey of sorts for me, and why it excites me. And so just to give you a brief overview before we go into the details, pediatric arterial ischemic stroke has a slightly higher male predominance, and this is actually supported by literature both pre-puberty and post-puberty. We're not sure why. It is about as common as brain tumors in children. And unlike the adult stroke risk factors, traditional adult stroke risk factors that include atherosclerosis, hypertension, diabetes, atrial fibrillation, only less than 1% of those risk factors make up the risk factors for pediatric stroke. And despite all the advances we've made in the past several decades, it's still a top 10 cause of death in children. And just to show you here, I'm just gonna try and close this for a second on my screen so you can see, oh, sorry. Going back, the incidence of pediatric stroke varies geographically, and this may be, and by different studies, and this may be part and parcel because of the definition that's being used in defining childhood stroke. So again, the focus of this talk is going to be really on the ischemic, arterial ischemic stroke, and I will touch on neonatal and perinatal stroke, but for the purposes, I'm not going to talk about hemorrhagic, metabolic, venous, and all sorts of inflammatory etiologies. So arterial ischemic stroke risk factors. What I wanted to highlight here is that the International Pediatric Stroke Study in 2011 looked at a cohort of patients across all the participating IPSS centers. And really the top two causes of stroke in children are both congenital and acquired arteriopathies, as well as cardiac disorders, both acquired and congenital. And so one thing I wanted to highlight with this slide is that arterial ischemic stroke in children is not a single entity, and usually there's a multifactorial synergistic effect. So while we can identify one risk factor, for example, let's say there is an arteriopathy, we often continue to look for other etiological factors like prothrombotic states, because we know that in pediatric stroke, it's usually not just one factor like atrial fibrillation that has led to the stroke. And sorry, I'm just trying to move. Forgive me for a second. I can see it's blocking my screen. Okay, let me just move this chat to the side so I can see better. So this slide is called the cascade slide. And so we know that in adult stroke, the most common risk factors are atherosclerotic risk factors, but we know, as I mentioned earlier, that less than 1% of those make up etiologies for pediatric stroke. And so the Childhood Arterial Ischemic Stroke Standardized Classification and Diagnostic Evaluation System, that's a mouthful, called Cascade, was developed again by the International Pediatric Stroke Society as a way to characterize the underlying etiology and help for future studies of pediatric stroke. And there are 7 categories, including cardioembolic, bilateral cerebral arteriopathy. So those are usually things like Moyamoya disease and syndrome. Then there's the unilateral focal cerebral arteriopathies, which can be inflammatory, or it can be vascular, like dissection. Then there's the arteriocervical arteriopathies, including extracranial dissections, small vessel arteriopathies of childhood, like vasculitis, and something called ADA2 deficiency. Then there's the multifactorial and other. And so those are the broad categories that have been used going forward in order to standardize a way of case ascertainment in pediatric stroke. It's important to know that there's many stroke mimics in children. And so this often leads to delays in diagnosis, both in hospital or pre-hospital and in-hospital delays. And, you know, studies from our own center from RAFE have showed that about 60-90 of children presenting to the emergency department with acute neurological syndromes have condition other than strokes. That means 10 children coming in with a focal neurological deficit, 1 out of 10 will probably have an actual stroke. So it's the finding Waldo in the array of all of these multiple stroke mimics. And so again, delays to diagnosis in pediatric stroke are common, including at our tertiary care center where we think everybody knows about pediatric stroke. There's lack of experience with pediatric stroke in the emergency department, even occasionally at our own center. There's frequent non-focal presentations of stroke in children, so not unlike the adults. And again, there's a much wider differential diagnosis, as I've illustrated in the previous slide. There's a bit of a geographic lottery, both within Canada, US, Europe, and across the world. If you're lucky enough to are lucky enough to have a stroke, but in a geographic center like Toronto, then you would be seen at the Hospital for Sick Children and hopefully diagnosed in a relatively quick manner. But if you're 2 hours away and you live somewhere outside, you may go to the emergency department, which is a general emergency department where they may not know about pediatric stroke or lack the diagnostic imaging or expertise and a delay with transfer. So that's always been an issue, regardless of kind of whether you're in a well-resourced or country or not. And we also know that even though CTs most of the time the go-to, especially at centers outside of sick kids, it has poor sensitivity to acute ischemia. And that's because CT often misses posterior circulation stroke. And there are a lot of stroke mimics in children, much more than in adults. So we do prefer to use MRI imaging to confirm the etiology before initiating any treatment. And so in terms of etiological investigation, so there's a really nice paper by Lisa Sun, recently came out, kind of gives you a standardized evaluation of pediatric stroke in an iterative approach. So where we start and where we go once we're getting into the more rare, weird and wonderful presentations. So we always we try our best to do an MRI. And just to highlight that stroke really is a vascular diagnosis. And what that means is if you're just doing a MRI or just doing a CT scan, you're not really looking at the vessels. And stroke is vascular by nature, whether it's small, medium, or large vessels. So we always say, and when I teach residents, that you need to image the vessels as well, whether it's an MRA or a CTA. It's really important that you get vascular imaging. Because we work in a big cardiac center at Sick Kids where there's cardiac transplant, a third of our cases do come from complex congenital heart disease. So we often do echoes. EKG sometimes picks up, very rarely though, this is more in adults, arrhythmias, and then basic coagulation studies to see if you can use antithrombotic therapy or fibrinolysis and some basic inflammatory markers. If all of this is coming back negative outside of the location of the stroke, then this is where we go into the more advanced diagnostic evaluations, and I'll just leave that for now. So what are the goals? The goals of acute stroke management are very similar, the same in adults as in children. And the goal is to make an accurate and rapid diagnosis, and then thereby salvage the penumbra that's not infarcted yet. And that's the acute stroke care. And then after that, you want to avoid secondary complications, obviously, like stroke recurrence, malignant middle cerebral artery syndrome, epilepsy, and educate and rehabilitate the child. And so we can protect, how do we make an accurate and rapid diagnosis and reduce the volume of the infarct? Well, we protect ischemic neurons and restore perfusion to ischemic tissues. And you can do that kind of in one of two ways. You can use neuroprotective measures, such as maintaining adequate cerebral perfusion pressure, augment it, or you can actually use reperfusion therapies, which we'll talk about in subsequent slides. So again, neuroprotection, protecting the ischemic neurons. Here are ischemic neurons, and we can do that by using our physical measures, such as avoiding low blood pressure. So for example, in Moyamoya disease, you really want to augment the cerebral perfusion pressure, give lots of fluids. Sometimes even very rarely we could use, something that can increase the blood pressure, cerebral perfusion pressure into the brain. You're avoiding hyperglycemia, fever, and obviously treating seizures very aggressively, even before they start. And then we can also use, this is from an adult slide I once used, there's also now more in emerging therapies that are medical therapies, especially in the adult population, that are trying to use like glutamate antagonists and other medications that slow down the ischemic cascade and prevent the penumbra from, from the infarct from expanding and closing in. So the first and most important neuroprotective measure is a physical exam. And so again, it's really important to examine our patients. Sometimes it's very hard to do this because of pharmacological paralysis and anesthesia. So a lot of the stroke patients I see are actually from the cardiac intensive care unit. And so they are sedated and paralyzed post, let's say, cardiac surgery. And so it can be very challenging, but it doesn't mean that we can do challenging things and attempt a neurological exam or try and lift sedation. So clinical examination is the cornerstone to get that accurate and diagnosis it rapidly. And so I hope that in the introductory slides, I was able to highlight how does arterial ischemic stroke in children differ from adults. So children aren't little adults, as you probably all know. So again, we have very rare presentations. They're finding Waldo, and they can be very subtle, and that leads to both pre-hospital and in-hospital missed or delays in diagnosis. There's a wide differential diagnosis for focal neurological deficits in children and many, many mimics. So we always talk about 9 out of 10 children with a focal deficit actually have a mimic as opposed to an ischemic stroke. And we have differences in coagulation vascular systems called developmental hemostasis. And obviously that leads to, there's different mechanisms of injury. And so therefore potentially different therapies. And then we also have, as I mentioned before, multiple synergistic risk factors. So even if you identified one risk factor like a PFO, it's not enough just to stop there. We always emphasize that you need to look for all the risk factors in pediatric stroke and not stop with one. And again, age-related differences in coagulation. And these are all complex etiologies. And lastly, and I think most important for our own kind of clinical practice is there are very few clinical trials, and there's a lack of evidence-based, randomized controlled trials due to relative rarity. And so when we do study pediatric stroke, we have to use the IPSS, like an International Pediatric Stroke Consortium, where we can pick up and together, given that the etiology is rare, but when combined, we can get better numbers and hopefully lead to better answers. And currently most of the, in fact, all of the consensus-based guidelines for management of pediatric stroke are guidelines only based on consensus and not on RCT data, unlike obviously in adult stroke where the numbers are much larger. But guidelines are evolving with time. So that was the introduction, and now I'm going to go into 3 subtopics and hopefully update you on the current advances in the management of stroke. And where to start, but to begin right with the most controversial, IV thrombolysis and mechanical thrombectomy. So again, when it comes to stroke, time is brain, and we know that in pediatric stroke, just like in adult stroke, IV thrombolysis, mechanical thrombectomy are therapies that we know can be done in specifically carefully selected populations. Additionally, we use anticoagulation therapy, antiplatelet therapy, and there's also actually RCT evidence for blood transfusions, exchange transfusions for sickle cell anemia. So in terms of acute treatment, we know that there's hyperacute treatment strategies are all extrapolated from adult data, and TPA or alteplase was been administered in about 5 to 7% of cases of pediatric stroke in the US. That's very recent data from Lisa Sun's paper, a nice review paper if you're looking to kind of look at a summary of everything I talk about today. But just to throw a wrench into what we finally got used to is that over the past year, a lot, if not all of our adult centers in Canada and US have started to switch over, if not all have switched over to tenecteplase, which has replaced alteplase. And so we're back to kind of square one and trying to understand, okay, well, should we use TNK in children, and how do we get some baseline data on the safety, efficacy, and dosing data? Of course, there's none available in children, and I'll talk about tenecteplase in a subsequent slide to highlight the differences between alteplase. We also know that fibrin clot structure can often be different between children and adults, and tenecteplase is thought to be more fibrin specific as opposed to alteplase. So there's lots of nuances here. So let's go back to TPA to start. TPA in adults. This is, how does it work? It converts plasminogen into plasmin, and plasmin is what degrades the fibrin, which is needed to cross in platelets and to form that, nice clot. And so in adults, this has been shown by randomized control trials that when you administer TPA within that 4.5-hour window, it significantly improves clinical outcome on the modified ranking scale, both within the acutely and within 3 months. And the increased and the risk comes at a risk of hemorrhage, and the risk of hemorrhage is about 6% of intracranial hemorrhage. So once you go above the 4.5-hour window, the risk of hemorrhage precipitously increases, and that's why it's no longer advised to give TPA outside that window. And so in the absence of contraindications to TPA, it has long become the standard of care in adult ischemic stroke. But as we know, stroke etiologies in children are different from those in adults and often multifactorial. So what happened in children? So in children, the interesting thing is that both my mentor, Dr. Gabrielle de Weber, and a number of IPSS coordinators decided to embark on a study to look at efficacy, safety, and dosing for TPA in children. And this was the only prospective treatment trial of IV TPA or any acute hyperacute therapy in children to date. And it's called the Thrombolysis in Pediatric Stroke Trial across multiple IPSS centers. However, unfortunately, it was closed due to lack of enrollment, and it was very stringent and specific criteria, which of course we needed to have in order to answer the question, requiring both confirmation of stroke on MRI and confirmation of a clot on MRA or CTA. But despite the fact that the trial never was able to answer the questions in a prospective fashion, it did lead to infrastructure development in a lot of hospitals that participated in the trials, to the point that we now have code stroke teams in those hospitals. And it also led to subsequent studies called the TIPSTER study, which I'll talk about in the next slide. So at our own center at the Hospital for Sick Children, if we were to have a child arrive with a diagnosed confirmed stroke on MRI and a clot, within that 4.5-hour window, which is a very tight therapeutic window by the time you get to the diagnostic interpretation of the neuroimaging and the arrival of the child, then the therapy of TPA is given at a dose of 0.75 milligrams per kilogram if the child's under 12, and 0.9, which is the adult dose. They both have max doses. And I just wanted to highlight that the distinction between 12 years old has no basis, really, if I'm being completely frank, in evidence and in pharmacological evidence. In fact, we know that endogenous TPA in children and younger children is actually much lower. So if anything, we think that maybe they would benefit from a higher dose, but of course, nobody wants to have a complication like an symptomatic intracranial hemorrhage, worse, that could lead to morbidity and mortality. So with children under 12, just completely arbitrary, and I don't have the full historical context of this, we've decided to go at a lower dose, and those that are over 12 thought to have less of that developmental hemostasis, more like adults, after puberty, and so using the actual full dose. So going back to what I was talking about, the TIPS study, while it had to be closed due to lack of recruitment, it did lead to the TIPSTER study, which is the study that was looked at retrospectively at 26 children that had come to those pediatric centers and received IV TPA. And it has the analysis of the TIPSTER study showed that, again, retrospective fashion, not prospective, that if the IV TPA in these carefully selected children was given within 4.5 hours of stroke, then the estimated risk of S means symptomatic intracranial hemorrhage was about 2.1%. So that leads us to believe that, children, again, this is a very small number of children. These are, again, very carefully selected children, that the number of children or the risk of intracranial hemorrhage that's symptomatic is a little bit less than the 6% risk that we quote with adults using IV TPA. And so there's now evidence and safety in TPA, but then comes tenecteplase. So tenecteplase made headlines in the last year and a half. And so what is tenecteplase, and why has it been used in adults now over alteplase? It's a genetically engineered mutant tissue plasminogen activator. And really, I would say the advantages compared to alteplase, while all of these are true, the biggest advantage to using tenecteplase in adult centers is that you can give it by a single bolus. You do not have to give the first dose over 10 minutes and then put on the IV drip and give the rest of the dose over an hour, because both of that delays transfer of the patient. For example, if the patient's getting TPA in an adult hospital, but they're not at a tertiary care center where there is someone that could do a mechanical thrombectomy, because that is also now standard of care in adult hospitals, then that really delays that patient going from that center to the subsequent center and getting a thrombectomy should the TPA not be able to recanalize the stroke, the clot. And so really the single bolus dose is probably the most advantageous. You don't have to fumble with it. You don't have to mix it. You just give it and you're done. It does have, as I mentioned before, a higher fibrin specificity and a longer half-life, and is a bit more resistant to plasminogen activator. In studies from adult literature, there's non-inferiority between alteplase and tenecteplase, which means that they're both equally efficacious and not one is really thought to be better than the other. Although anecdotally, I'm hearing from my adult interventional colleagues, they're seeing less adults who go on to have a cerebral angiogram right before they have a thrombectomy. They feel that the tenecteplase maybe is dissolving those clots. So a lot of the times after tenecteplase, they go in to do the thrombectomy and the clot's already distally recanalized or dissolved. Again, this is not based on, this is just anecdotal data that I hear. And so there's thoughts that maybe tenecteplase may result in more rapid reperfusion and lower intracranial hemorrhage rates in adults. But again, this data is not supported, and there's no efficacy safety data in children. And so if you're at a standalone hospital like Sick Kids, where we're just our own pediatric hospital, and we are not tied to an adult center, we're going to continue to use alteplase for the time being. Tenecteplase has no use in any pediatric settings. For example, alteplase is often used in our hospital to open up blocked lines. It's used in cardiac procedures when they're trying to dissolve intracardiac thrombi, but tenecteplase has not been used in any pediatric setting, so there's really no evidence behind it, or safety, I should say. And so this is where it becomes very challenging. Some of my colleagues work in pediatric hospitals that are tied to adult centers, and on their formulary, the tenecteplase is now being replaced. Alteplase is being replaced, or has been replaced, by tenecteplase. So when the next pediatric stroke comes in, if they fit the criteria to give TPA and there is no TPA, does the investigator then go on and give a single bolus dose of tenecteplase? It's obviously, this makes it even more murky. And I know that IPSS right now has a survey, is trying to address these gaps in our knowledge. And there's a survey ongoing about the use of tenecteplase, but people have used it kind of a case-by-case basis. And so far, we're just hoping that there's more mounting evidence in the future to help us guide what we do next. So that's enough on IV thrombolysis. I'm going to switch gears to mechanical thrombectomy and just looking for, I'm doing for time. And so mechanical thrombectomy in adults is really the removal of a clot from a blocked artery. And so we can use a stent retriever, an aspirator, which is basically suctioning like a Dyson vacuum cleaner, or a combination of both. And so this is a view of in the angio suite, this is a coronal view of a catheter being inserted up the internal carotid artery, and I believe going now into the proximal M1 there. And in children, we always require to use general anesthesia. And at my hospital, there's two ways of doing thrombectomy, femoral or radial. Most of the acute, hyperacute strokes go with the femoral axis, but we do when we do angiograms, for example, for moya prior to surgery, or a more controlled setting when there's not that quick, we need to be really, really quick. Radial access is also quite often being used, and it's easier for the patient, especially if they're doing a procedure and then they can go home, as opposed to someone with a hyperacute stroke. And so in adults, there were 5 randomized controlled trials, Mr. Clean being the first one, published in 2015, that did show the benefit of mechanical thrombectomy with a number needed to treat of 3. over medical management with IVTPA alone for large vessel LVOs, large vessel occlusion, stroke in adults with a less than 6-hour time window since last seen well normal. And you have to have evidence of a large vessel occlusion on CT or MRA. And then subsequent to this, there were 2 further studies called Dawn and Diffuse, and they actually opened up and extended the time window to 24 hours since last seen well in selected cases where there was perfusion imaging with CT, CTP, so that those patients with wake-up strokes could benefit from recanalization therapy, especially if they had good collaterals. So where do we stand on mechanical thrombectomy for pediatric arterial ischemic stroke? So the most updated guideline is from the American Heart Association, the American Stroke Association in 2019. And so what they say verbatim is that, you know, it's considerable, there's a consideration of thrombectomy in children if you have radiographically confirmed cerebral large artery occlusion, so a clot in the middle cerebral artery, anterior cerebral artery, basilar, and there's a pediatric NIH stroke scale of 6 or greater if we're using the Dawn trial criteria. So that's been a subject of debate, like how impacted do you have to be, what's considered severe deficit or not. So 6 is what been used in the adult criteria. So that's why we're sticking with that. And in larger children, right? So I'll get to that in a second. And the treatment decision, of course, has to be made in conjunction with neurologists and experts in the treatment of childhood stroke, as well as endovascular surgeons, pediatric neurosurgeons, or interventional radiologists with expertise in this. So going back to what does it mean to have larger children? One of the caveats to mechanical thrombectomy is how young can you do this? We know based on case reports that it can be done, and there's now mounting evidence that it is very feasible and in fact safe, but where do you draw the line? And so this came from a paper presented at the International Stroke ISC in 2019 that showed that by the time you reach 5 years of age, the relative diameter of your circle of Willis and the arteries, the major large arteries in the brain, reach adult size. So this is relative vessel diameter of adult size. So which is why initially we all thought, okay, 5 years and older, go for, if you know, more likely to benefit and less risk of tearing or dissecting the vessel. 5 years and younger, case by case discussion, you need experienced radiologist, and making sure that you have the equipment, most importantly, that can go into smaller diameter arteries. But this is what they mean by larger size. It doesn't necessarily mean by weight or age, or sorry, I should say by weight. So thrombectomy is increasingly being used in children, and that's just, again, a nice highlight of kind of the case publications from 2000 to 2019. As you can imagine, more and more cases were done. 2015 is when we had the adult data showed that there was a number needed to treat of 3, including with Mr. Clean, and then it kind of just went off and skyrocketed there. But the caveat is that there's definitely a publication bias. We're going to report cases that are successful, obviously, and who are the children that benefit the most from this? And I'll talk about that adolescents, really, and those with clots that are easily amenable to that, you know, suctioning device or pulling the clot out, such as cardiomyopathic clots, are usually the ones that are being published. So you can apply this generally to all sorts of stroke, for example, like focal cerebral arteriopathies, Moyamoya disease, sickle cell, or younger children. So again, mechanical thrombectomy, we have over 400 PEDS case reports published. Most of them are case report series, single arm cohort studies. They do show a favorable outcome. And again, there's a selection publication bias. Again, like I mentioned, adolescents and cardioembolic etiologies are largely what are reported in these PEDS cases. And so it is hard. This is kind of where myself and our Australian colleagues set out to try and figure out how do we know that the actual thrombectomy improves neurological outcome in these children. Maybe the natural history, which has always been the argument prior, that the natural history of pediatric stroke is that it has a favorable outcome, and therefore maybe those are the children that benefit, or that even if whether they had mechanical thrombectomy or not, they would have a good outcome anyways. So given that there's been more and more publications, it was really difficult to have the uptake of mechanical thrombectomy, especially in centers that are not familiar with pediatric stroke or have the expertise. And it was also difficult, it will be very difficult to conduct a randomized control trial, again, for lack of numbers and accrual rates and diagnostic definitions. As you can see, the TIPS trial had to be closed because of lack of enrollment. And so we just don't think it's feasible or ethical to do a randomized control trial in children, proving that mechanical thrombectomy is safe and effective in specifically selected population of children. So a lot of studies have looked into, are we selecting the right children for thrombectomy? And so this is a study that was published in 2019 from Sandra Biggie out in Europe and Maya Steinlen. And so they looked at 16 children who had recanalization. 11 of them had mechanical thrombectomy and 5 had IV TPA from 2015. And so they're looking in terms of relative safety. 5 patients, all with partial recanalization, developed malignant infarction requiring hemicraniectomy, and 1 died from in hospital, and 5 had poor outcome. The Saves Child study is by Peter Sporns out of the US in 2020. So 73 children again, looking at 27 from the US in Europe, from 27 US and European centers, again from 2000 to 2018. So 18-year cohort, and 1 patient had symptomatic intracranial hemorrhage. After thrombectomy, 3 patients developed malignant infarction requiring a hemicraniectomy. And so what we tried to do is look at, again, this is kind of looking at in a case control or a cohort study of publication bias. So what we tried to do, and what we did recently, is with Kartik Bhatia, who's an interventional radiologist in Sydney, Australia, we looked at our sick kids cohort and the Australian cohort and tried to do a case control match with historical controls, those that were not amenable to thrombectomy but had large vessel occlusion. Usually this would be before 2015, when really it took off in adult centers as well. And so what we did is we found that we looked at retrospectively at matched case control study, and we matched by age, by location of stroke, and by sex, in a 10-year cohort. And so we matched by site of occlusion, including internal carotid, M1, M2, or basilar, age group inside, and looked at the differences between the groups. There was no differences between the groups in terms of their age, sex, TPA status, baseline infarct extent. And so we had 26 that received mechanical thrombectomy plus minus IV thrombolysis, including sick kids and the Australia centers. And then we matched them to 26 controls, historical controls. Majority were 60% were male, and thrombectomy patients had significantly better outcomes at 3 months on the pediatric MRS, so the modified Rankin scale, and also at the last available follow-up. And this covered the age group between 2, so somewhere as young as 2 and as old as 18 years of age. And this is just showing from our publication that the pediatric modified Rankin score in the thrombectomies, you can see more patients are in the 0 to 1 to 2. So the MRS is basically 6 means death or severe disability, and 0 means completely normal functional outcomes. So you want to be on the 0 to 1 kind of end of the scale. And so the control group had a higher, or I guess more significant morbidity compared to the thrombectomy group, both at the 3-month MRS and then the final follow-up. So although again, this has a lot of limitations, we know that a lot of these children had cardioembolic strokes, that these were mostly adolescents. You cannot generalize to inflammatory arteriopathies. You cannot say that children that are young would benefit from this, but we were able to show in a non-randomized control trial that there is definitely some benefit to carefully selected. I want to underline that, not just any child, but very carefully selected children with a large vessel occlusion in an appropriate center where they have expertise for mechanical thrombectomy. So the summary of what I just talked about is that the natural history of large vessel occlusion stroke in children is poor, unlike other stroke etiologies. And IV alteplase appears safe and appears to reduce the PEDS NIH stroke scale in a small retrospective sample of 26 children. That's the TIPSTER trial. And so the uptake of APTPA is improved by the undertaking of this TIPS study. Mechanical thrombectomy appears to be safe. We know we can do it, but now we need to know who would benefit the most from this. And in a matched case control study that we published this year in JAMA Neurology, children between 2 and 18 received thrombectomy, did about 3 times better in the long term compared to patients who received just medical management, which would have been anticoagulation therapy or our neuroprotective measures. And existing stroke guidelines in children are yet to be updated based on all the recent data. I'll just skip this. This is just some future directions and debates, but initially, obviously, we're all going to be looking at any evidence of safety of tenecteplase and efficacy in children, extending time windows, and then for thrombectomy, things like this has become popular in adults, large infarct cores. Do you even need to do perfusion imaging? Should we just go into any large vessel occlusion, and especially with children have more robust collateral? So that's just future directions and debates. So I know I'm going to be running out of time soon, and I wanted to touch base actually about some preventive therapies in special populations, and what's near and dear to my heart is the cardioembolic population. And so maybe I'll cover that and then end with some of the new rehabilitation advances on the horizon. So I work in a cardiac center where there's children who are born with complex congenital heart disease who would otherwise have succumbed to their congenital heart disease and go on to have staged palliation or go on to have a full heart transplant. And so we do use a lot of ECMO, extracorporeal membrane oxygenation, and ventricular assist devices as a bridge to heart transplantation, or when children with complex congenital heart disease, have an infection and that causes cardiogenic shock. And what I wanted to highlight with this slide is that the prevalence and incidence differ of arterial, this is actually combined arterial ischemic stroke and hemorrhagic stroke. While the prevalence appears to be higher on a ventricular assist device, the incidence appears to be lower, and that's because ECMO can really support a child or an adult for about max 21 days until they have to be decannulated or brought to transplant, where a ventricular assist device can be used for years almost. So we've had children that have had it for almost a year. And so, but the lifetime exposure to the thrombogenic material is longer. And that's why the prevalence of hemorrhagic and ischemic stroke, especially when the Berlin heart was approved for use in children, was quite high. So 1 in 3. So even though those children otherwise would have died, succumbed to their congenital heart disease, they're being kept alive, but at a higher morbidity of 1 in 3 would succumb, or not succumb, but would have severe neurological deficit like a hemorrhagic or ischemic stroke. So that's the background. And again, what are ventricular assist devices? So these are used to support terminal heart failure, bridge to transplant. Stroke is the most feared complication. Again, I mentioned how in the past, the hemorrhagic and ischemic combined prevalence was as high as 1 in 3, let's say, so low as 28 to 47%. And so we have this increased risk of thromboembolic complications because obviously this is an artificial pump that's pumping blood and has a lot of nuances in terms of the flow rates, whether it's pulsatile flow or continuous flow, artificial vascular surfaces that contact the blood and then cause thrombosis. So children on these devices were always put on anticoagulant therapy and actually on a specific regimen of antithrombotic therapy. So why do children with pump and ECMO have thrombosis and stroke? Well, there's pump factors. That's the way to look at this. Pump factors, shear stress, device design. There's patient factors. Do they have a concurrent infection, a central line, procoagulable state, and therapy-related causes? Are you monitoring anticoagulation? Are they underdosed in their anticoagulation? Is there treatment of infection and pump speed settings, etc.? And we know that factors associated with brain injury on the Berlin heart, which is the specific pediatric ventricular assist device approved for children, were those children that were under 10 kilograms. So the very young, right, very small children were at highest risk of brain injury. And those are the children that, as remember, I took you back to mechanical thrombectomy. We talk about children, they have to be an average age of 5 to have the same diameter of the circle of Willis and large arteries. Well, clearly these are not those children. And as I'll mention, IV TPA and thrombolysis is not something that can be used in their cardioembolic population because a lot of the children that are have complex congenital heart disease are already on antithrombotic therapy. for valves, for prophylaxis, because they have a systemic clot. So, that's the #1 contraindication for IV thrombolysis. So if they do end up having a stroke, especially an ischemic stroke, the only therapy they would potentially be amenable to is mechanical thrombectomy. And these children are very, very small, so not always would be the case. And so what happened was, prior to the introduction of Action, which I'll talk about in the next slide, we used heparin as the anticoagulant of choice to prevent thrombosis in these children. The disadvantages of heparin is that it only binds free thrombin, and there's dosing challenges. A lot of these children, because they have congenital heart disease, they have a backup, especially if they're in heart failure, backup into their liver, and they lose proteins such as protein C, protein S, and antithrombin, which are natural anticoagulants, and you require antithrombin in order for heparin to work. So the dosing challenges exist. You have to dose heparin with antithrombin, and then there's also very rare but potential risk of heparin-induced thrombocytopenia. But you can reverse heparin really quickly. We like to use heparin at our hospital a lot for stroke prevention and secondary stroke prevention, because you can stop it, reverse it, take someone to surgery. And then came along in 2019, the Advanced Cardiac Therapies Improving Outcomes Network, that's called Action. And they decided that why not try something called bivalirudin? Now, it's a very expensive anticoagulant, and you can't go home on it. It's IV only, but it's a direct thrombin inhibitor, so bypasses antithrombin, and it's a new standard of care across pediatric centers that use ventricular assist devices. The advantages is it directly inhibits both free and fibrin-bound thrombin, has predictable dosing, and a very short half-life, so potentially you could stop bival, wait 25 minutes, wait till it washes out, and give IV thrombolysis. That's we haven't done that, but that's like the potential benefit. Oh, sorry. And there are no reversal agents though available for this. But what we've seen both at our own center at SIG Kids and in Action centers across North America and Europe, so that data is showing that there's decrease in strokes from that 30%, that would be 30% combined hemorrhagic ischemic, down to 12% after the widespread use of bivalirudin. And so at our own center, I don't want to jinx anything, but I can't remember last time we actually had a patient on a ventricular assist device have an acute stroke protocol. And that's probably because bivalirudin is really becoming the better anticoagulant and is helping the very specific population. So in the interest of time, I wanted to talk to you about Moyamoya disease and sickle cell disease, and just kind of the recent advances in its treatment, but I'm going to skip over that and go to some rehab advances and the rehabilitation and management of stroke sequelae. So we have some more time for questions and answers, and I'm happy also to share the slides if you want to have a look at the other sections.
Lisa,
so
you can, Dr.
Yeah.
Pulse, you can continue the talk if you want. So I think a lot of questions are about Moyamoya as well. So we have time.
We have time. Okay. Yep. Okay. If we have time, then I'll just kind of try and merge sickle cell.
We have time.
Okay.
We have time.
Okay.
Yeah.
Okay. So let's go to Moyamoya for the next 10 minutes. So what is Moyamoya disease? I'm sure you see a lot of Moyamoya, especially if you have an interest in pediatric stroke, because it's both a disease and a syndrome. And the classic definition is it's non-atherosclerotic, so it has nothing to do with buildup of plaques. It's non-inflammatory, although that's now kind of a source of debate. And it's a progressive vasculopathy. It can be unilateral, for example, a neurofibromatosis, but usually it is bilateral. And it causes narrowing of the distal internal carotid arteries. So up here, distal internal carotid arteries, and the proximal, we call this the T carotid junction, the proximal middle cerebral artery and anterior cerebral artery. And it was described, in Japan in 1969 as something hazy like a puff of smoke drifting in the air. That's where the Moyamoya name comes from. And that's based on angiogram, right? So not based on MRA or time of flight, based on a cerebral angiogram. And what you need to know, I'm sure all of you already know this, but it has two peaks, one in early childhood around 4 to 6 years of age, and then again in the 30s, 40s. So bimodal distribution. there's a slightly female predominance, but really it's probably the only time you see a slight female predominance in pediatric stroke. We know it's polygenetic. There is this ring finger protein 213 that's a susceptibility gene in Moyamoya disease, but we've had patients that tested positive for this but don't go on to have this specific progressive Moyamoya. And then there's patients that don't have this gene but have very severe Moyamoya. So it's not the one all be all, but we often use, especially in familial Moyamoya, we often test for this. It's higher prevalence in the Asian and Japanese populations. And of course, once we call Moyamoya syndrome is where there's comorbid conditions, including Down syndrome, neurofibromatosis, sickle cell, facies. And why it's important is that it is an arteriopathy, and just like cardioembolic stroke, which accounts for about 30% of stroke in the childhood population, arteriopathies make up about 50%. Moyamoya is a big part of that. And because it's progressive by nature, it has a high risk of stroke recurrence. And so for that reason, we need to prevent further strokes, and that's usually done in one of two ways: medical management and surgical management. So again, this is just to show that RNF213 Moyamoya spectrum, that there's Moyamoya plus, where there's not only a cerebral vasculopathy, but there's also renal artery stenosis. Sometimes there's vasculopathy in the heart, like pulmonary artery stenosis. And so, you know, I'm not a geneticist, but for those who are interested in Moyamoya genetics, Dr. Moran Hussein Kadem, who's part of the IPSS network, you know, is studying the Moyamoya genetics and populations in Israel, as well as Dr. Noma Delamini, who's the head of the pediatric stroke program at SIG Kids, has a big interest in Moyamoya disease. And so this is just to illustrate that it's becoming a spectrum, kind of like we think about other disorders like autism. And that there's, on top of that, some environmental factors and triggers that cause Moyamoya. For example, patients with sickle cell and Down syndrome don't always go on to have Moyamoya, but some of them do, and we don't know if they're the ones that have had some form of environmental factor or trigger. So what we classically see in Moyamoya are these watershed infarcts. So the areas of vulnerability between, for example, the major arteries like the anterior cerebral artery and the middle cerebral artery. And so this is the deep white matter. So when there's not enough perfusion into the brain because there's stenosis in the vessel, progressively occluding the vessel, we often see these watershed infarcts, a dirty white matter. And this is a T2 flare, axial cut at the centrum simia valley. And what you're seeing here is, it almost looks like this patient got contrast, right? Like, and if I didn't know, I would say, oh, maybe do they have an infection? Did they get contrast? But this is actually what we call the Ivy sign. And this is this serpiginous outlining of the sulci in the brain. And it looks like contrast, but I'll show you this is a non-contrast MRI. And what it's showing is, what we think it's showing is the PIA, the oxygen, the PIA is engorged and the brain is thirsty and needs more oxygen. And I'm going to guess that the Moyamoya in this patient's maybe bilateral, but worse on the right-hand side. And so this is as a way to extract oxygen, blood has to go slower through the PIA collaterals. And so this is synonymous to seeing this Ivy sign of these engorged PIA as the brain is thirsty and trying to get oxygen from there. And this is the puff of smoke appearance, all these collaterals on cerebral angiogram that replace the internal carotid, or I should say the intracranial and the middle cerebral, anterior cerebral artery. And so again, we talk about how medical management in Moyamoya is really augmentation of cerebral perfusion. So what I mean by that is, hydration. If a patient with known Moyamoya comes to our center, we don't consider IV TPA. We don't consider mechanical thrombectomy as our first lines. We consider hyperhydration, laying the head of the bed straight, or even sometimes reverse Trendelenburg to get more perfusion, although this is not based on evidence. It's just something that makes us feel better and hopefully increases cerebral perfusion. And then as a secondary prevention, we talk about putting them on an antiplatelet like aspirin or clopidogrel. Again, there's controversy about whether this actually makes sense to do and is preventive. But that's the mainstay of medical management in Moyamoya. I've yet to see a Moyamoya patient come in with a large vessel occlusion, so an actual clot that's embolized to the brain. Moyamoya, again, is a progressive non-atherosclerotic narrowing of those large vessels. And if the clot is not coming from somewhere else, it's not embolized, it's kind of in situ we think hyperperfusion as opposed to like clots forming and causing occlusion of large vessels. So again, because we're afraid of causing dissection on those vessels, a patient with known moyamoya is not someone we would consider, or, you know, we'd still discuss, but we would not consider mechanical thrombectomy or TPA in these patients. And because of a higher risk of potentially bleeding because of those collateral vessels that are very friable, right? In the adult population, moyamoya patients come in more with hemorrhagic stroke than ischemic stroke. And so the other way to prevent stroke in moyamoya disease and syndrome is to go for surgery. And so we are lucky enough to work with an experienced neurosurgeon, Dr. Peter Dirks at SIG Kids, who does, we call the indirect bypass. So what he usually does is looks at the extracranial arteries applying the face and looking at the cerebral angiogram for the superficial temporal artery. And that superficial temporal artery is dissected out and then put through a burr hole on the intracranial circulation, but not directly anastomosed to the middle cerebral artery, just really anastomosed to the pia. And then over time, over 3 to 6 months, that superficial temporal artery, basically like a plant, throws collaterals into a thirsty brain. And if the brain is starving for oxygen, those collaterals grow really rapidly and quickly. And so it's a way to bypass or augment cerebral blood flow to that area of the brain. And it's been shown to reduce stroke recurrence. But when you do the surgery, it takes months. We say up to 6 months before that, you know, that superficial temporal artery can cause that robust collateral. So you're not out of the woods yet. And so often in pediatrics, we do the indirect bypass because, as you can imagine, the brain is growing, the arteries are growing. And evidence or studies have shown in neurovascular and neurosurgical literature that if you do a direct bypass, where you actually anastomose the superficial temporal artery to the middle cerebral artery, all of a sudden it's exposed to this high pressure, high cerebral blood flow. And so there's higher risk of hemorrhagic complications. So in addition to the fact that the cerebral arteries grow as children grow, we tend to, at our center, do the indirect bypass. And so, you know, there's some controversy again in terms of a lot of what we do now is we pick up moyamoya disease prior to even a child presenting with symptoms. So for example, there's screening protocols for sickle cell disease when the TCDs are elevated, or transcranial Dopplers. And so there's a lot of controversy to do. What do you do with an asymptomatic child before they've had a stroke, but they've been diagnosed with moyamoya disease based on radiographic imaging? When do you intervene? Do you wait for their first TIA? Is that too late? Or do you go for surgery? And what subpopulations of moyamoya disease or syndrome progress and which don't? And one of my colleagues in Montreal, Dr. Leila Kaseka, has looked at the 3 different types of syndrome, most common syndromes of moyamoya, including sickle cell, Down syndrome, and neurofibromatosis. And it's felt that for the most part, neurofibromatosis has a relatively non-progressive moyamoya, unilateral, does pretty well. It doesn't always have to go for surgery, versus if you have sickle cell disease or if you have Down syndrome, that tends to portend a poor or more rapid evolution of the moyamoya. And those are the patients at our center that tend to be the ones going for surgery more often. But again, an area of much debate and controversy. And at our center, we are also lucky enough to use something called BOLD fMRI, or a cerebrovascular reactivity test, which kind of helps us to look for steel from the brain. And it's a test very akin to a cardiac stress test. So in cardiology, you know, when someone's complaining of angina, but someone does an EKG or a cerebral or a cardiac angiogram and doesn't see an occlusion, then they put the patient on a treadmill, make them run, and then they look for any evidence of, you know, angina during the actual stress, when you put the heart under stress. Well, this is a similar idea of putting the brain under stress, but with breath holding. And when you breath hold, you accumulate carbon dioxide, and that causes relative vasodilatation in healthy arteries. But then the ones that are moyamoya arteries, they can't vasodilate, they can't autoregulate because of the moyamoya disease. And so it happens, for example, this is a patient, 10-year-old patient from our center with right-sided moyamoya disease. And this is her cerebrovascular reactivity study before surgery. And I can tell you that she has right-sided moyamoya, and that there's steel phenomenon as shown by this blue area, because when she held her breath in the MRI machine, she had relative vasodilatation into the healthy side of her brain. So the healthier side stole, basically, that was the vessels vasodilated, stole the oxygenation or the blood flow into the left side. But then 4 months after, a right-sided syngiosis, that indirect bypass, that blue area seemed to be improving. And then 6 months after, this is why we say the surgery is not a quick fix. You still have to wait afterwards. You see that literally the map turns from the steel all the way down to the full red map, showing that the surgery has worked, and hopefully will prevent any further stroke recurrence in this patient. So I know, again, I'm not sure if I have the time, but sickle cell disease, very similar. All I wanted to show you is really this slide about sickle cell disease, is that it's really, when I talk about multiple and synergistic risk factors for stroke, I think of sickle cell disease because this is actually a great illustration of all the different types of stroke etiologies that can happen on sickle cell. You can have moya-moya disease and collaterals, but you can also have subarachnoid hemorrhage, venous infarcts, and moya-moya. You can have not necessarily moya-moya, sickle cell vasculopathy, where there's, extracranial or large vessel extracranial stenosis. You can have subcortical infarcts. Again, you can have infarcts from just the pure sickling inside the small vessels. There's lots of inflammation that can happen, and as you know, because of the sickling and splenic sequestration, these children are also more likely to have infections and bacterial infections that can cause an arteritis. So really, when I think of sickle cell, it's really complicated because most of the time you have to look for many different risk factors in this population of children. And so we know that patients at our center are followed with transcranial Doppler. And when their abnormal blood flow velocities in their middle cerebral artery reaches 200 milliliters per second, they should be considered for chronic transfusion therapy for primary stroke prevention, because if not, the studies show that you have a 40% stroke risk, whether it's silent or not, within 3 years following identification of this abnormality. And then again, we screen a lot of once we see that, we screen our sickle cell population with angiography, or I should say with an MRA, and look for moya-moya or other type of vessel abnormalities, beating, tortuosity, and not to forget, they're also at higher risk of aneurysmal formation. And that's just, again, another example of someone with moya-moya disease, sickle cell disease that has moya-moya syndrome, and you can see the moya-moya is probably worse on the MRA on the right-hand side than the left, and there's more white matter ischemia in the deep white matter on the right side. In terms of management for sickle cell, there's actually evidence and randomized evidence for this group, and the goal is really to do a transfusion, if you can, an exchange transfusion, if not, normal blood transfusion, and lower the percentage of sickle hemoglobin to less than 30%. And that's in the acute stroke recommendations. Again, we don't tend to go in with thrombectomy, because especially if there's a vasculopathy, because we're afraid that we would dissect the vessel or cause more harm than benefit. And I've never seen VTPA or tenecteplase or alteplase used in this population either. Doesn't mean that it can't be, but because of the higher risk of, especially if there's more collaterals, or they are at higher risk of aneurysmal formation. And so just to keep that in mind, the sicklers and the moya-moyas are not represented in that group of patients that are being published in literature of, or well represented and being published in literature of mechanical thrombectomy. So again, chronic transfusion, aspirin, revascularization surgery for moya-moya vessels. I know this isn't done everywhere and it's controversial, but we have done sickle cell patients that continue to have TIAs and that have moya-moya vessels and that show progression and show that steel phenomenon, and they've done very well. But not every moya-moya patient with sickle cell disease would benefit from the vascularization surgery. And then more curative treatments are now coming into play, including hematopoietic stem cell transplantation, which would halt, if there's progression, if there's moya-moya, could halt the progression of the vasculopathy. Obviously, getting a BMT or a stem cell transplant is not, is a hematopoietic stem cell transplant is very high risk, and it's not something to be taken lightly, but we've seen that in a few patients. And I know that there's some gene therapies probably on the horizon. So for the last, I'm going to talk for 5 more minutes I'll talk about some interesting rehab and management of stroke sequelae, and then I'm going to stop for questions. So bear with me. I know it's late. I know it's 10:40 here, but close to 9:30 where you guys are. So hopefully, I haven't put you to sleep just yet. But I wanted to talk about what we can do for children when they miss that acute reperfusion time window, because that's actually the majority of pediatric stroke, including at our center. Whether it is because of delayed diagnosis or other reasons, we have to focus on all of these other areas of management and rehabilitation. So I'm not going to talk about all of these. This is a nice review from Continuum and Stroke in 2018, but I just wanted to highlight a few. So the epochs of time following stroke and their targets, right? So we know that the hyperacute phase within the first 24 hours is where we talk about the acute therapies I mentioned previously, but what about within the acute, early subacute, and late subacute chronic phases? Is there endogenous plasticities or something that we can give to make that penumbra not fill in? Is there something we can give in terms of, besides our neuroprotective measures? And so currently our rehab protocols, consist of primary, providing a multidisciplinary team of occupational, physical therapy, speech and language therapy, and another major focus is prevention of complications like spasticity, dystonia. But what can we do outside of these areas? And so one area is in growth factors. This is where I'll talk about neonatal arterial ischemic stroke and something called erythropoietin, which you've all heard of probably with Lance Armstrong and doping. But it's been shown in experimental studies to reduce inflammation, and these are animal studies, and stimulate neuronal differentiation of neural progenitor cells and reduction of stroke volume in the rat brain. And so also leading to improvement in motor and cognitive outcomes. So then there was a human neonatal stroke phase 1 study that looked at recombinant erythropoietin and that looked at safety in 21 neonates, and they found that there was safety but no benefit on the effect of brain volume and stroke. And that led to the subsequent iterative development of the dinosaur study, which you may or may not have heard about. What's ongoing now, and we're one of the participating centers, where they're looking at infants with confirmed middle cerebellar arterial territory stroke in the neonatal period. And they're using a synthetic version of erythropoietin, so something called darbepoetin versus placebo, to look both at, again, stroke volume, reduction in stroke volume, and improvement in motor and cognitive outcome. And this is called the dinosaur trial. And prior to the dinosaur trial, there's been efficacy of visibility and safety of using this as a neuroprotective measure in hypoxic ischemic encephalopathy in children. So stay tuned for the results. It's ongoing right now. And I'm very excited from our neonatal stroke colleagues and our neonatologists to present results of the outcomes of this promising trial. Because as you know, the neonatal arterial ischemic stroke population, they don't have a time of lasting well. Their stroke etiology is mostly placental. We feel that clot, just by bad luck, travels through the placenta, through the PFO, and into the middle cerebral artery. And so they're not ones that could benefit from something like IV thrombolysis or thrombectomy for obvious reasons. But if we could, find those children by screening them for seizures, focal seizures, or encephalopathy with no specific HAE setup, and give them darbepoetin, and then reduce their stroke volume and improve their outcome, wouldn't that be just be an amazing feat and change kind of our management of neonatal stroke? And more, what I wanted to mention, this is a video. I'm not sure if I'll have time to, well, let me play it and see if it works. This is called a
Dr. Pulsine, we don't hear any.
Oh, you don't hear it? Oh, I'm sorry. Okay, so I'll do the commentary. Apologize, I thought the sound was on. So I wanted to just briefly talk about brain-computer interfaces. And this is a device that basically uses EEG technology, so electrophysiology, to have a child or an adult control a device with their thoughts and their brain waves And so this is just a study out of Holland Bloorview, which is a kids rehabilitation center in Toronto. And the gentleman was explaining how there was someone sitting at the computer and with his thoughts saying, okay, I want this little robot to move to the left, move to the right. And without touching it or doing anything, he was able to let this robot move. And so the reason I mention it is in the field of pediatric stroke, you probably heard of Dr. Adam Curtin, who's a professor of pediatrics in Calgary and has done amazing rehabilitation trials in pediatric stroke. And he often, if you have a chance to invite him to speak, I highly recommend, because he's a very engaging speaker and also a mentor. And so he talks about this is one of his patients. Now I know this is a patient that this patient had quadriparetic cerebral palsy, so not an arterial ischemic stroke in the classic sense, but her name is Peyton Temple, and she uses this brain-computer interface to paint. And although she's, confined to a wheelchair and is not able to use her body to the same way that we are, she's completely able to communicate via the brain-computer interface, and it really opens up a world of opportunity for children, especially children that have, for us, the locked-in syndrome. So where you have a basilar infarct, they're fortunately very rare. While their motor fibers are no longer able to function, their entire cognition and thoughts are completely intact. And so that's probably one of the most devastating strokes that we all see, and the outcomes of that. But Adam Curtin, Dr. Curtin's using all this very amazing technology to try and bypass and have children still live a meaningful life, being able to use technology such as this. So I don't know exactly the way it works, but if you invite Dr. Curtin to give you a talk, I'm sure he can explain it. It's very, very exciting. And so the last thing I wanted to mention before I take questions is brain stimulation. And again, this is the largest study from Dr. Curtin and his group out in Calgary that looked at repetitive transcranial magnetic stimulation combined with CIMT. So CIMT is basically where you take your good hand, or the hand that is not paretic, and you sequester it, for example, here in a glove, and you're using your hand that has the deficit to do unilateral tasks such as cutting, pouring water, etc. And so constraint-induced movement therapy combined with repetitive transcranial magnetic stimulation, along with intensive physio or occupational therapy, in this study really doubled the chances of clinically significant hand motor improvement in this cohort of children. And so there's something to be said about using these relatively non-invasive technologies to help once with the acute reperfusion therapies are no longer an option, and children have to live with stroke for their lifetime. So I'm going to stop there, and thank you so much for listening to me. I've left my email address here, so in case I'm not able to answer all the questions or we run out of time, feel free to email me, and I'm happy to reply to you. And again, just really thank you so much for inviting me and taking the time to listen. And I'm not sure how you want to do the question. And I know there's some things in the chat. Do you want me to go through them, or Manisha, are you going to moderate that question and answer period?
Yeah, so thank you so much. That was a fantastic talk. And before I invite the other experts, so we'll have some comments from our other experts. Madam Padma had to leave because of some emergency at her home, but we thank her for being here. And Dr. Kalpana Vijay and Dr. Tipu Sultan is with us. And I'll first invite Dr. Kalpana Vijay for her comments on the talk and any sharing of expertise for this particular topic.
Thank you for giving me this opportunity to be here. And thank you, Dr. Lisa Pulsane, for such an illuminating talk from her personal experience. And the comments I have to make is that even now we are not using TPA as well as mechanical thrombectomy much in pediatric practice. especially in our centers, because most of the cases will come very late outside the window period. And the second thing is that many of the cases we are getting have a relatively good recovery, but definitely with the TPA and thrombectomy, we may get a better outcome. But what we are seeing is what about the anticoagulation treatment? That is what we usually give for 5 to 7 days of heparin. What is Madam's opinion regarding that? Regarding anticoagulant therapy for children with stroke?
Okay, so
Large
I'll
vessel
just repeat.
occlusion like that.
Oh, large vessel occlusion. Okay, so the question was really about what type of antithrombotic therapy do we use in children with a large vessel occlusion, and for how long? So to answer that question, I think it always comes down to.
As well as.
Pardon me?
In the acute stage, in the initial period, we usually give an intravenous heparin for 5 to 7 days, like that low molecular weight heparin. And then regarding the continuation of aspirin or anticoagulants.
Yes. So in the prior to, I would say 2017, 2019, when we had a child come in with a large vessel occlusion, at our center at Sick Kids, and I think in the majority of Canada, we're very heparin happy because we have experience with heparin. So we would usually start with heparin 20 units per kilogram per hour. We wouldn't give a bolus, as long as there's no contraindications to give heparin, right? We wouldn't give a bolus. We'd start with that dose and then titrate it based on the antithrombin levels and the anti-10A levels. And then we would look for what caused that large vessel occlusion. So if, for example, this is a cardiac patient and they have, an intracardiac thrombus, well, it's almost easy. Then we know the cause. We would step them down to low molecular weight heparin. They go home on low molecular weight heparin injections for 3-6 months. Same thing with the dissection. And then until the risk factor is eliminated. So for example, if it was an intracardiac thrombus, if it was removed surgically or dissolved with the heparin or therapy, or if it was a dissection and we used serial imaging to look at the vessel and it was healing, there was no pseudoaneurysm, by 3 to 6 months, we would stop. But then that's the easy part, right? That's the easy etiologies. A lot of the times we don't know, we don't find a cardiac cause, we don't find a vascular cause. We often think that, to have such a large vessel occlusion in a child, it's either cardiac or there must be like some, silent dissection, or by the time we image them, a dissection is healing. So we tend to use anticoagulation as opposed to antiplatelet therapy. And we usually tend to use it for at least 3 months. And then based on repeat, etiological workup and imaging, step down to an antiplatelet. Again, etiology makes the most, makes the kind of what we would do going forward. And so I think the most important thing to say is that I've also I've also been to the Children's Hospital of Philadelphia, where I did part of my training, and there they actually tend to use aspirin more than an anticoagulant for things like dissection. Even if they were to find a dissection like extracranially on a cerebral angiogram or CTA, and even I think there's equipoise because they're not seeing higher rates of stroke recurrence from their dissections. And we are not, in Canada and Toronto, we're not seeing high rates of hemorrhagic transformation. So although the practice is different and some centers prefer to use anticoagulation, some prefer to use antiplatelet, usually for whether there's a higher risk of recurrence like arteriopathies in cardiac, we start with, at least in Toronto, with an anticoagulant, and then we continue either for 3 to 6 months or indefinitely until the risk factor is either eliminated or can be controlled. For example, like Moya Moya, this is the only example where we would probably use an antiplatelet, not an anticoagulant, until surgery. I hope that
thank you for the amazing, it was amazing talk. I will request Dr. Tipu Sultan from Pakistan to make his comments and his experience from Pakistan.
Thank you. First of all, I'd like to congratulate Professor Liz for an excellent talk and summarizing, though it's quite a lengthy talk, but still I would say summarizing such a complicated, for a general pediatrician or maybe a pediatric neurology fellow, a complicated topic, stroke in children, in a relatively easy way to understand and to actually implement this in their day-to-day practice. So I would like to have your experience, your comments, not only from Western perspective, but also from the Asian or Southern Asian perspective, because we do see mostly children, and particularly in summer season, when they have significant diarrhea, vomiting, and other causes leading to dehydration, end up a stroke. So should we consider acute stroke because of dehydration and because of underlying anemia and concomitant thrombocytosis, or in contrast, a definite cause leading to stroke like cerebral vasculopathy or arteriopathy? So your experience from the Western perspective, as well as my colleagues from the West Southeast Asian side, who may also like to comment on this relatively rare in the Western hemisphere, but not as rare in this part of the world.
For sure. Yeah, very complicated question. And I think to start with, again, I'm going to go back to stroke risk factors and etiology. And you're seeing, and that's true for our center too, let's say a child comes in with an infection, some kind of gastroenteritis, and they start vomiting and having diarrhea, and then they don't recover, or they can't be rapidly hydrated, and they get really sick, and then all of a sudden they come in with a focal deficit, and then you're supposed to, is this because they're hypoglycemic, or is this because they're having an arterial ischemic stroke? So stroke is a vascular etiology. So I think the first and foremost in any child with focal neurological deficit is vascular imaging. And again, the reason I take it back to vascular imaging, whether it doesn't have to be an MRA, it can be a CTA. In fact, I prefer CTAs sometimes, because that could have the perfect test to be like a diffusion MRI and a CTA, because the contrast really helps to show us what's going on in the arteries. We know that infection can cause arteritis, secondary arteritis, and stroke. So the child with a gastroenteritis who's coming in with a stroke, it's possible that whatever infection, whether it's E. coli or salmonella or something in between, enterovirus, can trigger an enteritis in the vessel. So I really want to make sure, in terms of the accurate diagnosis, but also prevention, secondary stroke prevention, that there's no problem with the large and medium arteries. Small arteries, we need to image in more detail, but most of the time these strokes are medium arteries. So, and some form of vascular imaging to show that there's no stenosis or, secondary arteritis. And then the other part of that is we do actually see, and I don't know if this is true, I'd be interested to know whether this is your experience. Most of the time when there's a child with dehydration and anemia, we are seeing venous strokes, like a venous thrombosis, causing then a secondary either hemorrhagic or bland infarct. So for some reason, like severe iron deficiency anemia on top of dehydration, or often these children, like that are young, 2 years old, they're coming in with a seizure, you image them, and then you see a venous clot and venous thrombosis in the veins, as opposed to an arterial stroke. And so whenever, if you just told me, I have a child who's coming in with dehydration, vomiting, and focal deficit and seizure, my mind always goes to venous before arterial. Again, different clot etiologies, like one's platelet rich, one's more fibrin rich. But in terms of my basic approach is always just to go back to the basics and start with, is this a stroke? Is this a stroke mimic? What the etiology, if it's infection, is probably synergistic combination of maybe an infection with some underlying genetic susceptibility. So let's look at the arteries, make sure that there's no stenosis narrowing. Do we need to put them on a antiplatelet, antithrombotic agent? And plus, is the dehydration causing them to have high hematocrit, higher platelets? But in that context, I would also really want to image the venous system, because that's usually the population of the dehydration. And if there's like a small inherited thrombophilia, which we never pick up, but let's say they have factor V Leiden heterozygosity, which doesn't mean you have a disease, it just means that you're maybe more predisposed for clot formation in a perfect storm, and then those children are tipped over. I'm not sure if that answers your question.
Yeah, significantly. Thank you, Liz. Thank you for your comments and sharing your experience. Thank you.
No, thank you so much. That's
So
very kind.
anyone from this part of the world?
Here also, we see more of venous infarcts compared to arterial infarct. Actually, there are more usually in these conditions with the dehydration, polycythemia, more of venous infarct compared to arterial infarcts. And also, what arteritis also can come as part of meningitis, because most of the children who come with diarrhea, vomiting, they will have a cerebral infection also, especially the very young. So arteritis, then the watershed infarcts can occur because of dehydration. So many things can occur depending upon the position, depending upon the imaging, only we can say. And a small percentage may be due to inherited coagulation factor, as Dr. Lisa has already mentioned. Okay, thank you.
Thank you.
Thank you, Dr. Sultan and Dr. Vijay, Kalpana Vijay, and thank you so much, Dr. Pulseen, for this fantastic talk. I know it's, I have a lot of questions in the Q&A box, but we, it's the time is running out, and definitely we'll have some comments from Madam Gulati and also the organizers on this. I'm so sorry. My apologies to all those questions there. Most of them have been answered actually. So if you, we will pass them on to Dr. Pulseen, and her email ID is there, and so you can always ask her, give her an email, and she'll be happy to answer. So thank you so much, Dr. Pulseen. That was a great talk. The summary points were definitely there, and we are wiser here. And thank you so much, Madam Vijay and Dr. Sultan, for your inputs. And I hand over the mic to Dr. Gulati now for her closing remarks and wrapping up the session, please. Thank you.
Thank you. Thank you very much, Dr. Pulseen, for an excellent talk and excellent discussion. I think you covered everything holistically. Thank you very much. And I thank all the attendees as well, and wish all of you a very happy new year. And we'll meet again in the next year. Thank you so much. Have a good day to you, Dr. Pulseen. And many people are from across the world. So good morning, good afternoon, and good evening. And happy new year to everyone. Thank you so much. Thank you. Mahesh, you want to say something before we just close? Mahesh, we can close? I think we can close then. Okay. Thank you so much. Thanks. Right. Bye. Thanks.
Thank you so much.